This video is the fourth part of a series on the topic of the function of the disc of the temporomandibular joint. Part 1 was on our understanding of why disc derangements happen and how to prevent them. Part 2 is a discussion on the concept of the vertical holding fulcrum and the mathematics of occlusal reduction from maximum intercuspation to centric relation, which we refer to as jawbone geometry. Part 3 is titled Centric Relation and Equilibration of an Orthotic. It is about capturing centric relation and then adjusting an orthotic using the vertical holding fulcrum and jawbone geometry. This part 4 is about the steps required to alter a natural dentition's occlusal surfaces in order to achieve centric relation. Part 5 will cover establishing anterior guidance and adjusting lateral interferences. It'll be on the steps required to achieve total patient comfort. Adjusting the occlusal surfaces of the natural dentition is much more difficult than adjusting the surfaces of an orthotic. And that is because you are dealing with angular contacting surfaces, and they can be retrusive interferences or surtrusive interferences or lateral disclusive interferences. In addition, you are usually dealing with all three at the same time. The engrams on which the muscles are functioning are constantly reinforced whenever the teeth come together. So the problem is to overcome those engrams. You're also adjusting both the upper and lower occlusal surfaces and have to understand what interferences are likely to show up as the process continues. To get this job done accurately and efficiently, there are a number of skills which one must be able to do well. It all starts with having accurate casts to work with. Dr. Tom Abrahamson produced an excellent video on how to take proper alginate impressions and make accurate casts. It covers the entire subject in exquisite detail. It is available through the American Academy of Restorative Dentistry's website in the Through the Eyes of the Master video series. It is a revealing but discouraging exercise to look at the mounted casts in your colleagues' offices. On the left are typical bubbles that one sees on the occlusal surfaces, and on the right the cast has been groomed. Sloppy work is self-defeating. A face bow must be properly used so that the mounted casts are reasonably accurate. This is a model which my dad made in the 1950s when he was teaching the importance when locating the true hinge axis of the mandible for doing full mouth reconstructions. When we record the bite, the centric relation record, there is a recording medium placed between the teeth, which means the jaws are separated. The vertical is increased. After the lower cast is mounted, we then close the articulator to occlusion. If the axis of the articulator is not the same as the patient's axis, then the occlusion which we observe between the casts is not really what the patient's occlusion is. The ear bow face bow, which is the commonly used face bow today, is an approximation of where the axis hopefully is. This is the adjustable face bow and mounting jig which my dad designed and we used routinely. It only takes a few minutes to locate the real axis, and it is so very much worthwhile. He had a series of slides on where the theoretical arbitrary axis was supposed to be and where it really was, and they were often at least a quarter of an inch apart. His model is mathematically accurate to demonstrate the error which occurs when there is a quarter of an inch of error between the real axis and the facebow transfer from an earbow. It is instructive to see what type of error occurs when one is just a quarter of an inch off from the true axis. This is the error produced when the articulator axis is a quarter of an inch behind the true axis. This is what happens if it is below the true axis. If it is in front, then the occlusion will be open and back and the front teeth will be in the way. And if it's above, then the entire occlusion will be protrusive. Techniques for obtaining and recording centric relation were discussed in the previous Part 3 video. One must take a protrusive record and set the angle of the eminences in the articulator in order to accurately visualize what the difference is between MI and CR. Place the casts in maximum intercuspation and then see where the ball is. This gives you a reasonable estimate of how much detrusion and protrusion are present in the MI position. In other words, you will see how much retrusion and how much surtrusion will have to be accomplished during the equilibration. If you use a whip mix articulator, it is essential to cut away the outer wall to visualize where the ball is when the casts are in MI. Cut back the part with the X on it. When you are through, it should look like this. The lighting in the photograph is a little misleading. We have not touched the fossa, only the outer wall. In addition, the back wall of a whip mix is curved to accurately house the ball. That is a problem because if the patient's MI condylar position has a pure detrusion, that curved back wall will not allow the articulator to accept that condylar position. You have to cut the lip away in order to create a vertical, flat back wall. In the previous video, we worked with the vertical holding fulcrum on the maxillary orthotic, which was a relatively simple thing to do because it was a flat surface against which the lower cusp tip could articulate and slide against. It is an entirely different thing when one is dealing with the anatomy of a lower cusp within the anatomy of an upper opposing fossa. In spite of this, the same principles of the VHF still apply. You most likely have two curved surfaces contacting on an inclined plane. As one adjusts the interferences at the VHF to retrusion, it is very difficult to maintain a flat plane relative to the plane of occlusion. The solution to this is to add a composite resin in the fossa, have the patient close to establish the depth or the vertical at the cusp tip, and then adjust the composite along with the tooth structure, maintaining a flat VHF. Something to keep in mind is the retrusive pathway that cusps take through their opposing fossae. It is an oblique movement, not down the central groove. That statement assumes that the amount of retrusion required in each joint is approximately the same. The advantage of being able to look into the fossa of the articulator is that you can make that judgment in advance. The movement will be parallel to the midline of the mandible. So the reduction in the lower arch is into the buccal triangular ridges. In the upper arch, it is the opposite. The interferences for the lower cusp tips are mainly the upper lingual triangular ridges. This is the BHF fossa, which you are keeping perfectly flat. Remember the discussion about jawbone geometry. The rest of these fossae most likely have to get progressively deeper as you transition from the second premolar to the second molar. The main problem that one faces in this equilibration process is overcoming the engrams of maximum intercuspation. Here are 8 examples of the engrams which one must contend with. This is our Rube Goldberg setup so that we could take movies of what the ball in the articulator does when the casts were moved from MI to CR. For 8 different patients chosen at random simply by the last 8 patients for whom one of our study club members had mounted casts. This is a mild condylar posture change from MI to CR. Another with a mild amount of change. This one requires a huge amount of surtrusion and a little bit of retrusion. This one is pure surtrusion and is the one that required that we cut the curved lip off the back of the articulator fossa so that the articulator could accept the MI posture. This one is some of each. This one was mostly surtrusion. And this one required retrusion only. Regardless of what method one uses to attempt to coax the mandible into centric relation, the process of marking the interference tends to reestablish an MI pattern which is not centric relation. A helpful trick is as follows. Once you assume you have coaxed the mandible into centric relation, then ask the patient to close in back light as a feather. They should feel the first interference. Ask them to touch that spot a few times to memorize what it feels like, to remember it so they can go back to it. Then mark that interference, adjust it, and then ask the patient to touch it again. And if you have not cut it completely away, they can go right back to it again. And you can repeat this process until you have eliminated that first interference. This saves time. It is my personal opinion that finding the interferences to retrusion, marking them and eliminating them, is a relatively simple matter compared to finding and eliminating the interferences to surtrusion. I think a little bit of protrusion in MI is harmless because the joint is designed to function that way. However, any amount of detrusion in MI has extreme risk. It is the disc posture relative to the condyle that is the critical factor, because if the disc is in a protrusive position to hold the condyle away from the eminence, that's what sets it up for degradation and eventual anterior disc displacements. In our hands, an abbreviated version of the cotton roll protocol has to be repeated many times to be certain that the disc position has been resolved to its ideal centrofovea posture. Part 5 of this video series is on adjusting anterior guidance and eliminating lateral interferences. After that is accomplished, then we recommend doing exactly what Dr. Wilson did on the maxillary orthotic. Have the patient close in back and grind hard in little bitty circles and adjust those posterior fossae until the last trace of detrusion has been eliminated.